Hello, everyone. Welcome to a very special VMR. We're very happy to present today a new series. You might be very familiar with Neuro VMR. Well, today we will start Nephro VMR. For all of our nephro enthusiasts, we have a dear VMR member that I know that many of you might recognize from the chat, Dr. Rich Snyder. Hello, Dr. Rich. He will be our attending and leader in
Hey,
this
David.
new series. Would you like to introduce yourself and tell us what you like to do outside of medicine?
Yeah, just real brief. Rich Snyder. First off, as I said to Yaz and everybody, I'm in awe of everybody here. I've listened for the past several weeks to discussions and a level of discussion. I mean, you're all phenomenal, and I mean, it's just a privilege to be here. And like, I hope I can do this case justice. Briefly, I've been a nephrologist for about 15 years. I've also been involved in graduate medical education. I was a former IM internal medicine residency program director. The one thing I do want to say is I've written about 9 books. I've done books on kidney disease, liver disease, dialysis, test preparation for nursing students, physician assistants. Currently, I did a book last year on hypertension for Wiley. I'm just finishing up a second draft for kidney disease, and then I'll be doing a book on pharmacology. So that's in a nutshell. So yeah, I'm pretty much kind of a more of a remote kind of guy. So, but it's a privilege to be here and interacting with you guys, and thank you so much for the opportunity.
Yeah, thank you. And we are, it's very amazing everything you have been doing for medical education. And in the seat of co-discussant, we have our dear attending Dr. Mark. Mark, friend, would you like to do this yourself?
Hello, hello. Yeah, I'm so honored to share the stage with Rich. He just has so many amazing kidney pearls in the chat, and it's just going to be so awesome. I actually first wanted to be a nephrologist when I was in probably early during residency, and then I just started liking like all the subspecialties. So I'm like, why don't I just be a hospitalist? But I do have a special love for nephrology, and I just like love renal physiology. So can't wait to learn from Rich and to nerd out about the kidney.
No, you guys bring amazing cases. Mark, you brought some great cases. You really have.
And today, as our presenter, Mariana, we have two great women IMGs in the presenting seat, Mariana and Simi on the teaching points. Would you like to say some words? I'm passing the mic to Mary.
Can start. Hello, everyone. I'm Mariana. I am international medical graduate from Brazil. I'm very happy to be here today. Um, Dr. Rich Snyder, please feel our warm welcome. We are very pleased that we are here with us to start this new series. And yeah, let's jump in right into the case. Simi would like to say hello.
Hello. I am Simi and I'm doing teaching points today, and I'm very excited for our first nephrology VMR. So really looking forward to today.
Whenever you're ready, Mari.
All right. So for today's case, just give me 1 minute. I had it open right here. I'm sorry. So, all right, for today's case, we have a 65-year-old male presenting with left lower edema and redness. And I'll stop here.
Should I start or Mark?
Sure, if you want to start, yeah, totally up to you.
Yeah, I mean, I'll start. Certainly left lower extremity edema and redness. Usually in things in the nephrology world, we're thinking about things that will affect the venous system in general. So you're looking at processes which can cause or affect bilateral lower extremities. Certainly, if it's just one limb with edema and redness, I mean, common things you'll think about, cellulitis or erysipelas. Could the person have a superficial venous thrombosis? Could the person have a deep venous thrombosis? Would want to know a little bit more of history. Would also want to know, for example, did the person have a surgery of saphenous vein grafting for some type of cardiac surgery where they may have an asymmetric edema, which may predispose. Is there any type of process which could be affecting venous flow? Like, for example, could the person have some type of malignancy or venous obstruction, lymphatic obstruction, which could affect, venous flow on one side, causing asymmetric leg edema? So like, for example, for something like retroperitoneal adenopathy, retroperitoneal fibrosis, iliac venous clot, something isn't more superficial up. I'd like to know if there's more than just right leg affected, although certainly if it's just more than unilateral, you would expect something further up for, more of the venous system be affected. Mark, what do you think?
Yeah, totally. And Marianne, just to clarify, there was nothing, the right lower extremity was completely normal.
Oh,
Nothing.
I'm sorry. I can't read, can't take me any place. I meant unilateral lower extremity. Sorry about that.
Oh, no. And Marianne, is that true? It's just like one extremity is red and swollen? Is that true?
So both of them are red, but the left worse than the right.
Gotcha. And they're both swollen as well?
Yes, correct.
Gotcha. Okay. Yeah, I was honestly going to not add anything else to what Rich said, because in real life, if it was just unilateral redness and swelling, it's 95% of causes would be cellulitis, a bacterial, skin infection, or a DVT. So I would start there, and I would usually finish there in real life, obviously. But the only thing I'll add is that, we have talked a lot about, lower extremity edema on VMR, and kind of just thinking about the three organs that are affected, right? I know this is a kidney VMR, but you can think about the heart, the liver, and the kidneys, right? And some diseases affect, both the heart and the kidney at the same time, right? Classically, we can think about something like amyloidosis, but there's a lot of other connections you can make. But in patients like this, I definitely do a very good volume assessment. Check out their JVP, ask if they're having any signs of left or right heart failure. You're going to get a chest X-ray or NT-proBNP. You're going to get liver function tests. You're going to get a basic metabolic panel, and I'll definitely going to pay close attention to the urinalysis as well to see if there's any bit of proteinuria. The redness is interesting. You'll hear people say that, bilateral cellulitis is not a thing. And it really, like, if you have someone that has, like, especially if the onset was at the exact same time of, redness in the lower extremities, like, you probably should search for other things besides cellulitis, because cellulitis is usually unilateral in nature. I know it seems like the left lower extremity is more red than the right, but, a classic mimic is, venous stasis causes a lot of redness a lot of times too, and a little bit of swelling. But I would be cautious to call this like bilateral lower extremity cellulitis. But yeah, I'm really thinking about the big three organs, and I would kind of focus my lab testing and my review systems on those three organs.
I'd also want to know more about the redness, whether or not, where it is. Is it more predibial? Is it really more of an erythema nodosum? Is it more of something else to another chronic illness that could be occurring, something like, sarcoid or inflammatory bowel disease? Again, wanting to know more about that. I saw in the chat someone had talked about nutcracker syndrome. Again, certainly anything that could compress the renal vein, increase venous pressure. Certainly, they would have other symptoms. No, I'd want to know if they would have any hematuria, if they'd have any flank pain, things that will go along with increased, things that can affect renal venous pressure. I'd want to know if there's anything like, ascites, would want to know more about some of the physical exam findings as well.
Yeah, that's why I feel like that's why it's so important to do a good review of systems. I just had a patient the other day that got sent in for heart failure because they had lower extremity edema, but in reality, they actually had a infiltrative pancreatic mass encasing their inferior vena cava. So if the syndrome doesn't fit for any of those organs being down, like Rich is saying, just think about vascular compression. So that was an interesting case, and highlighted, how the lower extremity edema was kind of out of proportion to their cardiopulmonary symptoms.
Awesome discussion. So for the next aliquot, I'll give more information about the HPI. So this patient, he has a history of hypertension, dyslipidemia, peripheral artery disease, the left being worse than the right, active tobacco use, and also heart failure with preserved ejection fraction, kidney disease, stage 3A, presumed to be hypertensive, and hypothyroidism. And he firstly presented to the emergency department with 2 days of left leg swelling and tenderness. So he reports that he was in his usual state of health until 2 days ago, when he first noted that his legs were both feeling numb more than normal. And then his left leg started having more swelling, redness, and he started having some pain when he walked. And I'll stop here.
So this person has stage 3. You said stage 3A chronic kidney disease, which means they have an estimated GFR anywhere between 45 to 59 milliliters per minute. He also has a history of heart failure with preserved ejection fraction. So he was diastolic dysfunction, hypertension, hyperlipidemia, and hypothyroidism. He noted, you said, numbness in both of his legs, and then he began having more swelling. And this began 2 days prior. Certainly need a little bit more information. Was he talking about numbness like paresthesias in the leg? Could he feel his feet touching the ground? He also has would want to know if he was having any claudication type of symptoms. Sometimes if you have a clot in the leg that is so large it can affect arterial blood flow, we get legophlegmasia, ceruleum dolens type of thing. Again, that's not common. But it's, you still begin to think, is the issue with the pain more of, is he having so much swelling in that leg that it's making the neuropathy worse? Does he have a pre-existing neuropathy? And then you have compression from, if you have worsening swelling in a unilateral extremity, that's going to make neuropathy or nerve pain worse. Is there an issue with blood flow in that area? I'd like to know if he has had any trauma at all to that area. I'd want to know if he's had any surgery to that area in terms of, again, left leg being worse than the right leg. With neuropathy, this could be the beginning of a systemic process. Could it be something that's ascending? I don't know if he's having any other neurologic complaints. I'd want to know if he's had any falls, if he's had any dizziness. If the neuropathy is getting worse, is it ascending up the leg? Has he had any loss of bowel or bladder function? Those are things that I'm just kind of beginning to think about. Is this the beginning of a syndrome that we need to kind of get a better sense of? Go ahead, Mark.
Yeah, I'm pretty worried about the neuropathy. Like if it truly started 2 days ago and was very acute neuropathy is never a good thing. It's usually pretty sinister. I mean, the thing that we most of us think about is AIDP or Guillain-Barré syndrome. That's why I think doing a good neurological exam to see if the patient has objective, pain, temperature, proprioceptive defects, and to really see what their reflexes are. Because like I said, acute neuropathies, AIDP, GBS, acute toxins, something in the lumbar spine. So I definitely want to get more clarity on kind of like that time course. Like Rich was saying, has this patient been having, neuropathy for quite a while, which is not uncommon for a 65-year-old with metabolic syndrome to have neuropathy, and it just got worse? Or is this truly like, snap of the finger and it kind of developed right there? Because then I would kind of rush to more, diagnostics. I would move to quickly toward more like maybe advanced diagnostics. Another thing I would do quickly in this patient, and most hospitals do have access to this, is just a DVT ultrasound, especially when you have acute unilateral pain. Again, like I said, the last aliquot, pain and given it started on the left side, pain and swelling, definitely want to make sure the patient doesn't have a DVT. And then if they do have a DVT, then we'll kind of talk about, what the, trigger for that DVT could be. The other thing too is I'm very curious about the patient's hypertension control. And also like they have a history of CKD stage 3A. I'm curious about what the cause of that was. I'm interested to hear from you, Rich, because I feel like and you're definitely the expert here. I feel like hypertensive nephrosclerosis, like chronic kidney disease from hypertension. I've heard from a few nephrologists in the last few years that the association is getting like debated, and like it mainly is like driven by like APOL1 if it is present, and that like we should really question the diagnosis if someone says like CKD is mainly driven by hypertension. So I feel like recently I've kind of made sure that there's no other causes of CKD before I kind of label someone as, okay, this is CKD likely from hypertension. But I think like seeing how uncontrolled their hypertension would be really helpful in clarifying that. But yeah, Rich, I'm curious, what is your thoughts on that?
So ApoL1 is a distinct syndrome, usually seen in younger people, usually more in African Americans. It's usually been associated with focal segmental glomerulosclerosis and a cause of renal disease in the young population. If you see young males, especially African American males, on hemodialysis, there's a link between hypertension. I think it's a collapsing variant of focal segmental glomerulosclerosis. And anyone with the ApoL1 gene, they're at high risk of developing renal failure at a young age. And it's usually a tie-in of those three diagnoses together. So someone who's at 65, I don't know that I could implicate the ApoL1 gene in terms of just from what we know about the ApoL1 gene in terms of the group that it affects. My apologies, I'm a tad nervous, so if I'm stuttering, I apologize ahead of time. In terms of hypertensive nephrosclerosis, hypertension is still the second leading cause of why people are on dialysis. So diabetes represents about 1/3 of why people, or 1/3 of the patient population on dialysis. Maybe another 25% is hypertension, and then you have an overlap of about 10 to 15%. And many of them often have renal vascular disease. Certainly, in someone who's presenting like this with stage 3 chronic kidney disease, I want to do my due diligence and look for everything else. After a while, it becomes what comes first, the chicken or the egg, because hypertension can cause chronic kidney disease. And the most common cause of resistant hypertension is chronic kidney disease. So if you were to look up, before we even start thinking about things like renal artery stenosis and hyperaldosteronism and everything like that, if they have chronic kidney disease, it's likely going to be the cause, and it becomes, a chicken or the egg type of phenomenon. I do think hypertensive nephrosclerosis is a real thing. Certainly, I'd want to know, at the age of 65, I'd want to know what this person's history is. I mean, there are telltale signs of hypertensive nephrosclerosis. Certainly, if they have evidence of end organ damage, is there, hypertensive retinopathy? Is there LVH on EKG? Is there evidence of, vascular disease? You're looking for, evidence of end organ damage, malignant, or of hypertensive, chronic pathologic type of change. You can see tubular interstitial disease with hypertension. Usually you see increased echogenicity, and also they'll have tubular range proteinuria. So hypertensive nephrosclerosis in and of itself is a real phenomenon. And certainly with the newer guidelines, more and more people are diagnosed with hypertension, especially with the new hypertension guidelines, which began, from the AHA-ACC in 2017. So I think it is a real diagnosis, but I agree with you that, I want to know, like, for example, something you talk about neuropathy. What does this guy do for a living? Because certainly if he has hypertension, he has chronic kidney disease, he had a history of gout, lead nephropathy, that could be, an etiology for, why you could have peripheral neuropathy. So especially with chronic kidney disease, I want to know country of origin. I want to know ancestry. I want to know nationality. I want to know occupation. I want to know medications. I want to know all, over-the-counter medications, because it all will play a role to give a comprehensive, what's going on with this guy.
Awesome. That's such great clarity. And yeah, the only other thing I'll say too is with the HFpEF, I try to be as specific as I can, especially in like one-liners. And, HFpEF is really not like an endpoint diagnosis. Now, the most common cause of HFpEF is just metabolic syndrome. And we're realizing that it is really just another aspect of metabolic syndrome. And that's why there's been positive studies with things like GLP-1 receptor agonists for HFpEF. But, amyloidosis is becoming, increasingly, listed as a pretty common cause of HFpEF. And, we do have treatments for it now. So it's really important to identify it. And, amyloid as a cause of neuropathy as well. So maybe if this is a more subacute to chronic neuropathy, this patient has CKD, they have HFpEF, I'd be very curious what their echo looks like if they have a very, classic amyloid or infiltrative pattern. But anytime you see HFpEF in the chart, just make sure that there's nothing else on the echo that looks like maybe more of an infiltrative pattern, that this patient could have like a secondary cause of HFpEF is just the other thing I wanted to say. But yeah, Mariana, back to you.
I mean, just to add
Fantastic.
to, I'm sorry, I'll be real quick, just to add to the amyloid aspect to this, again, as you know, there's two different types of transthyretin amyloidosis, which, you know, is the most common types. And there's a new medication, I think this is Vindanzia, something like that, that's been used. I was part of an institution that was doing stage 3 critical trials for that. And of course, you're always worried about, you know, AL amyloidosis, but you know, you would expect more. Certainly, again, that could definitely present with neuropathy uh, and changes. It wouldn't explain the difference in the lower extremity symmetry. But again, certainly in this age group, you have to think about amyloidosis, you know, especially with heart and kidney disease being present. Great point.
Right. So let's move on to the next aliquot. So I'll give you a little bit more about the HPI and family and social history. So he smokes 1 pack of cigarettes per day. He reports 4 standard drinks of alcohol per week, and he also smokes marijuana intermittently. About the medications, he is on aspirin, on atorvastatin, on hydrochlorothiazide, and on lisinopril and levothyroxine. For the physical exam, his blood pressure is 169 over 63. The pulse is 65 beats per minute, and the temperature is normal, 36.9 Celsius degree. And a respiratory rate is 16, and he's saturating 99% in the room air. In the general physical exam, he's not in acute distress, and he's alert and oriented times 3. For the hack hint, sorry, he has like intact extraocular movement, and also his pupils are equal, round, and reactive to light and accommodation. And also he has moist mucous membranes. For the cardiovascular system, there are no murmurs or gallops. The rhythm is regular, and there is bilateral lower extremity edema, and as I mentioned before, the left is worse than the right to mid-shin, and there is no GVD. For the pulmonary exam, it is clear to auscultation bilaterally. No crackles or wheezes were appreciated. For the abdominal exam, the abdomen is soft, is non-tender, non-distended, and there are normal bowel sounds with no organomegaly. For the neuro exam, the cranial nerves were intact, and the strength was 5 out of 5 throughout all the extremities. For MSK, there was warmth and mild erythema on the left chin to mid-calf, and also tenderness to palpation in the left lower edema, left lower extremities. I'm sorry, and 2+ edema in bilateral lower extremity, the left being worse than the right. And for the skin, the skin was intact without any skin breaks, with onychomycosis on both feet. And there were no lymphadenopathy. And there's also an image. I'm not sure if Yas can share the screen with the image so you can see that.
Was the edema pitting or non-pitting?
Just a sec. Oh, wait.
Dr. Snyder, I did not personally take care of this patient, but
That's
from
okay.
what I see in the image, I believe it's pitting.
Okay.
Oh.
All right.
Can you see it?
Yeah, definitely can definitely widen circumference of the left leg compared to the right. Definitely. I'd be surprised if there's not a positive Homan sign on the left side. That's for sure. Yeah. Okay. Definite difference. That's impressive. Okay. First thing, before we go to the physical exam, I'd like to look at the medications. And there is one significant interaction that I want to point out to you guys that's kind of important to be aware of. So this person smokes marijuana. Okay. And again, the marijuana, one of the things about marijuana is it inhibits CYP3A4. So if depending on the frequency, again, when we talk about nephrology, you always want to look at meds, look at things that people are doing, over-the-counter supplements. So marijuana inhibits CYP3A4. So if you look at the medications the patient's on atorvastatin. Atorvastatin, and that's the main one that's inhibited by CYP3A4. So is simvastatin. Rosuvastatin is not. So if someone's developing more myopathy, more pain, I'd want to know if there's any myalgias or anything just related to that medication interaction. So just be aware that marijuana can inhibit CYP3A4, especially if someone has a history of kidney transplant and on a medicine like Prograf for tacrolimus, which is a common one because that can affect its metabolism, and elevated levels can cause acute kidney injury in a kidney transplant patient because Prograf is an afferent arterial or vasoconstrictor. Those are common medication interactions or common interactions that you're going to see. So just to kind of be aware of that. Everything else that the person is on, hydrochlorothiazide, lisinopril, again, is on. You would expect at least stage 2 hypertension if they're on 2 different medications, and the patient is on aspirin. So there's, looking at the legs, certainly, I think just looking at this, I'd want to know if the patient has any periorbital edema. That would make sense in terms of hypoalbuminemia and nephrotic syndrome with something being a cause. I think in looking in that left leg, I share Mark's urgency of wanting to get a venous Doppler. But I think, if there may have been some, if Doppler is negative, there may have been some pre-existing venous insufficiency, which is now just being worsened by a more systemic process that's causing low extremity pitting edema. So again, remember, edema is 3 liters of fluid in the interstitial space. Interstitial space is normally a potential space. So if you have 3 liters in there, that's when you begin to see pitting. All right. And again, different causes. You start from the you look at the heart, you're looking at the liver. Is there pulmonary hypertension? And of course, 2 major causes from the kidney aspect would be if this would be part of something like nephrotic syndrome, or if the person just has advanced or worsening AKI on CKD or advanced chronic kidney disease affecting the ability to excrete sodium in free water. If we're making the assumption that this is, I'm going to make the assumption, and again, I tend to anchor, and my apologies for that, that let's say the Doppler is negative, and then we're looking at, okay, bilateral lower extremity edema, and we're talking about nephrotic syndrome. The mechanism of nephrotic syndrome causing low extremity swelling is not really what we think it is. There's actually a syndrome called hereditary analbuminuria, where you have people who are born with low albumin levels, and they have albumin levels less than 2, and they don't develop lower extremity edema. The mechanism of hypoalbuminemia actually causing edema, and they've worked this out in animal models, is if someone has hypoalbuminemia, it actually causes distal sodium retention, and it causes that you get upregulation of the receptors in the distal tubule of the kidney, and that's what kind of contributes to the sodium retention. So the flip side is, if you're seeing someone clinically and they have an albumin of 2 and there's no lower extremity edema, they are likely volume depleted or have decreased effective arterial blood volume. So again, I don't want to make assumptions on nephrotic syndrome, but I'm going to make the assumption we're dealing with a systemic process. The fact that the heart and lungs are clear makes it less likely that there's heart failure. Again, there's no JVD, there's no S3, there's no S4. Less likely pulmonary hypertension, although can't rule it out. There's no JVD, there's no abdominal fluid wave. Then you look at the liver, certainly, any process within the liver, but Chiari syndrome, things like that, in terms of where you have backup of venous flow, but you would expect things like more of ascites. You're not really seeing that. You're not seeing any venous collaterals. You're not seeing any stigmata of chronic liver disease on physical exam, no telangiectasia, spider angiomas. So I'm going to make the assumption we're dealing with a more renal limited process or something that's affecting venous flow. maybe proximal to the IVC. Again, you could have worsening AKI on chronic kidney disease, could have nephrotic syndrome. If we are dealing with nephrotic syndrome, and I'll just finish up with this before we get to the labs. Again, you're dealing with more than 3.5 grams. Understand when they did that study, that was an arbitrary number that the investigator decided. He could have decided 4.2 grams, but we would have decided that to be nephrotic syndrome. Hypoalbuminemia from renal loss. Again, edema, and then hyperlipidemia because the liver makes, is increasing synthesis of proteins when it's sensing decreased plasma oncotic pressure. If the nephrotic syndrome is severe, then you could have loss of anticoagulant proteins like antithrombin 3. Procoagulant proteins. So you have loss of procoagulant, but you have more of that ratio of anticoagulant proteins loss, so you can develop increased risk of deep venous thromboses. These patients are also at increased infectious risk, especially if you're dealing with severe nephrotic syndrome, because you're losing immunoglobulins as well. So the humoral immunity aspect, they can also develop iron deficiency because you're losing iron carrier proteins. Again, we're talking severe. And then usually, etiology of severe nephrotic syndrome, it's usually something like minimal change. A membranous wouldn't necessarily present like this. It tends to be more friendly. But if you get sudden onset of mast nephrotic syndrome, at least in your differential, is minimal change in FSGS, so they're thought to be part of the same continuum. Again, but I am anchoring, and I tend to have a bias with that. But that's what I got so far. Sorry if I went off on a tangent.
No, that was awesome. I could listen to you talk about the kidneys all day. I think I don't have much to add. I'm just like rushing towards that venous Doppler ultrasound. Just thinking about like acute limb emergencies, right? Because this patient is presenting really acutely, DVT, acute limb ischemia. I would be very interested in the pulses. Usually acute limb ischemia from like arterial insufficiency usually doesn't look like this. But if we have a cool leg and that would definitely be concerning, especially given the patient's history of PAD. But like Rich, like you said, like a nice what am I looking for? Like if this patient had, say, cellulitis or a DVT, that'd be like with nephrotic syndrome, that'd be a nice kind of connection of those two, like or three like etiologies, because since nephrotic syndrome increases the risk of those conditions, like you mentioned. But luckily, it seems like we're not getting a heavy signature for like raging infection. Patients afebrile, didn't report any fevers or chills at home, but we'd be very curious about the CBC. But yeah, I'm just kind of keeping like acute limb emergencies in the back of my mind. And then also, again, like the time course, like, I know this patient's pretty hypertensive. I wouldn't be surprised with their history if they're pretty hypertensive at home. And I find it really helpful to always look at the outpatient notes to see kind of where the patient lives. Well, let's say the patient lives like a blood pressure of like 120/80, which again, I doubt they do, but have they really developed like bilateral, mainly left, like, lower extremity edema over a couple of days? Like, are we dealing with a glomerulonephritis as well? I mean, I think the urinalysis will be really helpful, but yeah, I think it's helpful to frame this as more acute or chronic, hypertension. And then I'm also keeping an eye on the pulse pressure too. Common things being common, this is probably just arterial stiffness from like an older patient, but could that be a sign of any other condition like a valvulopathy or anything else? But yeah, I'm very, very curious about the basic labs.
One of the things about the vitals real quick, I mean, again, there's a widened pulse pressure and what you mentioned. I mean, there was no evidence of anything like aortic insufficiency on physical exam. But and certainly the other things you think about is a high output state, but the patient is bradycardic, and the patient is markedly bradycardic. And I'd want to know if the patient was taking this levothyroxine and how they were taking levothyroxine. The most common cause of someone coming in with levothyroxine with elevated TSHs are not taking the medication the right way, especially if they're not waiting an hour from other medications to take it, or even taking something like coffee. I've had patients who have come in with bradycardia. Again, I'm not saying that the patient has mixed edema, but what I am saying is certainly with the bradycardia and this presentation, although it seems to be more pitting than non-pitting, I'd still want to know what a TSH's level is on this patient. Is giving the bradycardia and lower extremity swelling. So makes sense, especially with that pronounced bradycardia. Sorry if I keep repeating myself. All right.
Fantastic discussion. All right, so for the next aliquot, I'll give you a few labs. So sodium was 135, potassium was 3.5, chloride was a 94, CO2 31, and the anion gap was 10. Glucose was 90, and urea was 36. Creatinine was 1.6, and the baseline was 1.5. The total protein was 6.2 and the albumin was 2.6. The white blood count was 16.7 and the hemoglobin was 11.3. And the platelets were 367. And I'll stop here.
What was the glucose really 990? No? Okay.
Glucose 90, yes.
Okay, you scared me for a second. Okay. Well, in looking at the lab, certainly the patient has a leukocytosis with neutrophilic predominance, which could certainly go along with the patient's presentation with swelling and pain. It seems to be the one localizing aspect. There's no other aspects for at least that we can see right now of any other infectious etiologies, although certainly want to keep an open mind. Certainly would want to look at other things, look at chest X-ray, though he has no pulmonary aspects, UA, although again, it's very uncommon for a man to have a UTI. So if you see pyuria and you're suspecting, you need to do more of a further workup. Is it prostatitis? Is there a history? Other things to look at. Looking at, the sodium level that seems to be stable. The patient has chronic kidney disease and is at their baseline. The patient has I'm going to say 3.5, but I'm going to say normal potassium on the low side with an elevated bicarbonate. Again, certainly elevated bicarbonate could either be metabolic compensation for respiratory acidosis or, primarily metabolic alkalosis. The patient is on hydrochlorothiazide, which could certainly do that. But again, if someone has a bicarbonate level of 40 or higher on a BMP, there's at least a primary metabolic alkalosis, because you can never compensate for either a bicarbonate greater than 40 or less than 15. So if you're in between, you don't know which one is which, but the person could have a bicarbonate of 40. The metabolic alkalosis is not the primary, may not be the primary process, but again, in order to really know, you would get a VBG. Again, that's less of an issue here. Now, the patient has an albumin of 2.6, does not have an elevated total protein. Certainly, if the total protein was elevated, you have an increased albumin globulin ratio. You'd be thinking, is the elevated total protein a monoclonal or polyclonal process? Monoclonal process, again, you'd be thinking about things like multiple myeloma, plasma cell dyscrasia, light chain amyloidosis. They have a 10 to 20% overlap between those two conditions, and would be doing that workup. Hypoalbuminemia, again, we're going to make the assumption that we're dealing with a renal cause, but remember different causes of hypoalbuminemia. First is albumin is an acute phase reactant. So if there's a chronic illness, it's made by the liver, you're going to see less of that being made. Malabsorption, any kind of malabsorption can cause it, anything from history of gastric bypass, celiac disease, small bowel malabsorption, tropical sprue. One of the things I always look at when I see low albumin, I look at the medications, because I believe it or not, I've had 2 cases of olmesartan-induced enteropathy causing a malabsorption and low albumin level. Again, not common, but described just with that medication, not a class effect. And then certainly, again, so we talked about liver, we talked about malabsorption, and then you have renal losses. So someone presenting like this, again, I'm going to make the assumption of, I want to know what the urinalysis shows. I'd want to know what an albumin creatinine ratio and protein creatinine ratio shows, because if there's a significant difference, normally urinary albumin should be about 60% globally of your total urine protein. But if you have elevated urine total protein and a low albumin, that's going to point more towards means that there's other protein like Benz-Jones proteins or things like that in the urine. So you'd be looking at things again like a multiple myeloma, amyloidosis, light chain, which in this person's age group you would think about. Again, I'm jumping the gun, so I'd want to know what the urinalysis and protein creatinine ratios, are. But assuming we're going in that route, given that I don't see any other reasons for lower albumin level, One could argue acute illness, but I don't think cellulitis would be that much to cause a low albumin level, unless you're talking about, sepsis or other, which this person does not have. So I'll stop there. I don't want to go off on a tangent until I get some of the urinary studies back.
Hey, Rich, I was also kind of like interested in the bicarb as well. I think trends and history is like so important, like looking at this patient's like baseline like bicarbonate levels, because they definitely have some risk factors for like chronic chronic respiratory acidosis. Not that we don't have a history of COPD, but we do have a significant tobacco use. I wouldn't anchor on that because honestly, like I feel like most patients that have respiratory compensation have like decent COPD and probably would be symptomatic like at that point. And most places a VBG is very easy to get. So in cases like this, just honestly, sometimes out of academic curiosity, I just get a VBG and make sure that I'm, attributing the elevated bicarb to the right process. But like you said too, I was curious that, that low normal potassium is like, are we getting some features of, hyperaldosteronism? Could that be driving our, chronic hypertension and maybe CKD, but we are on hydrochlorothiazide, so that could be obviously like a confounding factor as well. But yeah, I found the bicarb interesting, and I would have a low threshold to get a venous blood gas and kind of just confirm that. And something like this, honestly, I'd probably just put them on antibiotics for simple cellulitis. This looks like a non-prurient cellulitis. So at my institution, usually these patients get IV cefazolin, a first generation cephalosporin, to treat the cellulitis and kind of see how the leg improves. But again, still want that DVT ultrasound, and I'm still very interested in the urine. Mariana, what was the urine studies? Very, very curious.
Yeah, Mark. So the team that was taking care of this patient also initiated the patient on cefazolin with some improvement of in the erythema, but the edema persisted. So they also performed an echocardiogram, which showed concentric left ventricular hypertrophy. The left ventricular systolic function was normal, and the left ventricular ejection fraction was from 60 to 65%. The right ventricular systolic function was also normal, and the IVC was in normal size, and they were unable to evaluate the diastolic function. The BNP was 300, and the urinalysis showed 3+ protein with no other findings. The urine protein in 24 hours was 1,177, and the urine creatinine was 184. And I'll stop here.
Did we lose Rich? Looks like he might be frozen. Oh no. Oh no, I think we lost Rich. I can start if that's okay. I would love to hear Rich's thoughts, but yeah, I can start. Yeah, Marianne, thank you for the echo. This echo most commonly is going to be from hypertensive heart disease, right? Or aortic stenosis, like a 65-year-old with hypertension and CKD that has left ventricular hypertrophy. Like that's by and far going to be the most common cause. I would definitely look at the echo very closely and just look for any features of amyloidosis. These aren't exactly sensitive, so the absence of them that definitely does not rule out amyloidosis, but things like biatrial enlargement, mitral and tricuspid valve thickening, the classic cherry on the top, if you do strain imaging as well. But it sounds like we're not really getting a signature of that. But in someone with, now we'll talk about nephrotic syndrome, I would definitely send an SPEP, a 24-hour UPEP, and Kappa and Lambda free light chains. And yeah, really, honestly, we kind of clinched the diagnosis right now of nephrotic syndrome. If I'm doing my math correctly, it seems like this patient probably has about 9 grams per day of proteinuria. I usually like to quantify that over 24 hours, and that's what I hope Rich teaches us as well. But I've usually been told by nephrology it's just better to. Oh, hey, Rich! I'm so glad you're back.
I lost connection real quick. I don't know what happened. My apologies. I'm sorry.
No worries. No worries. I kind of was talking about the echo a little bit, how I thought, most commonly it's going to be hypertensive heart disease. There's no classic features of cardiac amyloidosis, not that rules out amyloidosis, but in someone that we're already going to initiate a nephrotic syndrome workup in it, I always will send like an SPEP, 24-hour UPEP, and kappa and lambda free light chains in someone like this. I'm very curious of your thoughts of like, I've been told by nephrology in the past, maybe it's more of the like in between cases, but it's just better off to get a 24-hour urine protein analysis, especially if you're going to get the 24-hour UPEP than like a spot urine protein to creatinine ratio. And I would love to hear like what you think about like what would make a spot inaccurate. Yeah.
It's just a policy in every institution that I've been in that for a urine protein electrophoresis, you're going to do a 24-hour urine collection as well as a 24-hour urine creatinine, because the problem is you're looking at protein synthesis over 24 hours, and a random urine protein electrophoresis may miss what's going on at that one point in time. It's the same way of thinking about. You had mentioned about hyperaldosteronism. Not that I'm saying this is, but the one point that I just want to make about hyperaldo, the way that we diagnose that, where we get an aldosterone level and renin level in the morning, that's not enough anymore. There's a new way of looking at aldosterone, because aldosterone, just like insulin, is being synthesized 24 hours a day, right? Even if it's an autonomous secretion. So if you have a high suspicion for resistant hypertension and someone is on 3 different medications, and you get an initial aldo renin level that's normal, you need more data points by checking it at different times of the day. Usually for serum SPEP, I'll get a serum protein electrophoresis, immunofixation, serum free light chains. But for the urine, I'm getting a 24-hour urine because it's going to be more of a accurate representation of what's going on with the synthesis of the protein, especially if there's significant proteinuria. You won't catch it just with a random UPEP. So interesting.
Yeah.
So the urinalysis shows
lots of 3+ proteinuria.
So urine protein. Okay, now I see it. So a protein creatinine ratio. So that's at least about 9-10 grams of protein. So I'd want to know an albumin creatinine ratio. But in someone who's presenting like this, I mean, your main differential for idiopathic, I'm going to say that this is nephrotic syndrome, and I don't have a lipid profile, but I'm going to say that this makes the diagnosis in the sense that you have protein creatinine ratio more than 3 grams, 3.5 grams over 24 hours. Hypoalbuminemia. The patient does have lower extremity edema. The asymmetry, is going to be either DVT or cellulitis or a combination of both on that side. And they probably will also have hyperlipidemia as well. In terms of differential diagnosis, your big 4 is going to be amyloidosis. So your big 4 for idiopathic nephrotic syndrome is going to be amyloidosis, minimal change disease, membranous nephropathy, or focal segmental glomerular sclerosis primary. Now, in terms of how you triage what's what, it really depends on really the age of the patient. In a child, it's usually a minimal change disease until proven otherwise. And because of the prevalence in children that age, they won't even do a kidney biopsy. They'll just start the patient on prednisone. Adolescents and young age, it's either going to be FSGS, especially if we're talking about African American. You mentioned ApoL1 as a significant cause. Idiopathic membranous is also can be seen more in Caucasian. As we get, over the age of 65, number 1 is going to be amyloidosis, and can't rule that out. Minimal change is also going to be a big cause, especially with someone presenting with, now this person doesn't have massive nephrotic syndrome. They're not globally anasarchic in terms of how they presented, but the severity of proteinuria of 10 grams or approximately 10 grams is certainly enough that you're going to think about it. Now, minimal change, amyloidosis, in adults, primary AL, there's different forms of it. There's, secondary amyloidosis, but that doesn't normally fit here because usually that's seen in the setting of a chronic inflammatory state. Chronic osteomyelitis, inflammatory bowel disease, things like that, where you have a chronic inflammation going on, don't really have that sense of a history from this patient. So primary amyloidosis, again, hemoglobin 11.3, as Mark, as you pointed out, need to know baseline. Want to know what this person's hemoglobin level was 6 months, a year ago, see if there's been any decrease. Certainly you look at BARC, BARC phenomenon, although certainly with myeloma, you look at things, if it's an IgG myeloma, you can see a decreased anion gap. You wouldn't expect to see that much of an elevated bicarb, but IgG will cause a decreased stain-ion gap because it's cationic. IgA will cause an increased stain-ion gap because it's anionic. And your most common causes of myeloma are going to be IgG and IgA. In terms of immunoglobulins, IgD is actually the third most common. IgM, Waldenstrom's, would also be in a differential, is a large molecular weight protein. Again, and you're looking for overlap with that with amyloidosis, but you'd be sending those paraproteinemia studies as you were thinking about. If this is minimal change, again, would expect more of a more minimal change in FSGS, so thought to be on a continuum. They both will have foot process effacement on electron microscopy primarily, but with minimal change. Again, usually we have more massive global anasarca, more severe than what you would see here. For minimal change, there is a connection with malignancy, although you see that more as a paraneoplastic phenomenon with membranous. But when you're thinking about minimal change, you're thinking about lymphomas. It's very common with B-cell lymphoma. So depending upon, once this person ends up getting, assuming we're going to go for a biopsy, I would get a CT of chest, abdomen, and pelvis because I don't want to know if there's a lymphoma process or something else that's going on. You could have a primary FSGS as well. In terms of other things that can cause minimal change, in infectious etiologies can do it, medications can do it big time. Lithium, NSAIDs can do minimal change or can also do membranous. Membranous would also be in the differential diagnosis. One of the things about membranous, and we'll talk about that when I think about membranous, how I think about it. So there is idiopathic membranous, which is your phospholipase A2 receptor antibody, and you can order that as a blood test. They can also do special stains on the kidney biopsy as well. Then you start thinking about secondary membranous, which certainly like paraneoplastic membranous would be in my differential as well. This is a person who has a history of tobacco use. So certainly you could have a physiology of a lung cancer causing a paraneoplastic phenomenon, usually seen with solid organ cancers, lung cancer, breast cancer, colon cancer. Those are going to be your main ones. Any solid organ cancer can do it. It has been reported with some lymphomas as well. Certainly other things that can cause lupus, I would say lupus serologies, although it would be weird to present at this stage, it is class 5 membranous. RPR, if the person has any risk factors for syphilis, syphilis can also cause membranous nephropathy, as can hepatitis B and hepatitis C. So I would also send hepatitis serologies. Part of my workup, because again, I would also send complements. I would send paraprotein studies. I would send hepatitis studies. Things like anti-GBM and ANCA, we end up sending as part of a serologic panel, although those patients would expect to see with more of a glomerulonephritis. Now, this patient, the kidney function is at their baseline. The baseline is 1.5 and it's 1.6. So it's not really, this is an acute nephrotic syndrome. There's no mention here of any hematuria, of any type of red cells or red cell cast, dysmorphic red cells. So I don't know that I would necessarily say that this is an acute GN. But I would be thinking about those 4 things. I would be checking a serologic workup. I would get the DVT. I would also get a renal ultrasound because I'd want to know the size of the kidney. I'd get an abdominal ultrasound. Didn't really mention about hepatosplenomegaly, but infiltrative processes, you can see it enlarged hepatosplenomegaly as well. Amyloidosis, the kidneys tend to be enlarged. HIV, I would get if the person has HIV risk factors. HIV classically, there's 2, classic presentations is HIV-associated nephropathy, but that's usually associated with a primary FSGS and an acute kidney injury, which is not present here. There's also something called HIVIC, which is HIV-associated immune complex deposition. Again, that's going to be more of an acute GN. We don't really have that flavor here. But certainly, again, I'd want to know HIV risk factors. I don't think it would hurt to do that. But renal size, amyloidosis tend to have bigger kidneys because of the infiltrative process. Multiple myeloma can also be associated with enlarged kidneys as well on longitudinal diameter. Talking about clot phenomenon, any type of nephrotic syndrome can be associated with the development of a thrombophilic phenomenon. Usually is when your albumin approaches 2 or less. And again, it's because of the loss of those procoagulant proteins in the urine. However, of all the causes of nephrotic syndrome, membranous has the highest risk of developing venous thromboses, particularly renal venous thromboses, but it can develop thromboses anywhere. And the thought is they have elevated levels of tissue plasminogen activator inhibitor. I think I got that right, TPA inhibitor, compared to other causes of nephrotic syndrome. So again, any type of nephrotic syndrome can cause a hypercoagulable state. Certainly someone with this degree of proteinuria, you're going to be losing a ton of other kind of proteins, which increases the risk of other things. We talked about hypercoagulability state. We talked about infectious risk. You lose like iron carrier, you lose carrier proteins for things like iron. You can develop iron deficiency, vitamin D deficiency. And of course, hyperlipidemia as well. I would want to look at the urine microscopic. I'd want to see if we're seeing nephrotic syndrome. Those are things like oval fat bodies. This is things you look under a dark microscopy for, to see what they describe. And then go from there, a serologic workup. And then obviously I'd want to start the patient on diuretics. And we'll talk about that because with hypoalbuminemia and chronic kidney disease, the question is, what's an effective dose of diuretic you're going to start this patient on? Again, I'm babbling, but that's kind of where I am right now with this patient.
No babbling at all. That was awesome. And I'll just summarize. I can't summarize everything you said because that was just awesome and so much rich information from the hospital perspective. And correct me if I'm wrong. What I typically send is an A1C for diabetic nephropathy. For infectious serologies, I typically send an HIV hepatitis panel and an RPR to screen for syphilis. I send lupus serologies. I send a phospholipase PLA2R antibody for primary membranous, and then I do a thorough, screening for, malignancy, any signs and symptoms. But for serological workup, that's typically what I say. Was I missing anything?
No, I think I would send complements too, because I think if the complements are, they're acute phase reactants, they should normally be elevated. So if they're low, they're either going to be not being made or they're being consumed. And then the question is that the primary, the direct pathway, alternative pathway. But if they're low, it would go along with things like lupus nephritis. It would be kind of a unique history for a class 5 lupus nephritis without any prior history of this. Doesn't have any other ACR criteria, photosensitivity, malware rash, any of that other stuff. But yeah, and that sounds. If they had hematuria and if there was evidence of a GN, then I would add the ANCA and I would add the anti-GBM. One quick point about ANCAs, and is something that I've learned, the hard way with this. ANCA is an indirect immunofluorescence, right? So you want to send the indirect immunofluorescence as well, because you can have a person with a negative ANCA and positive NPO. You can have a person with a negative ANCA and positive PR3. So if you're going to send the ANCA, send the NPO and PR3 titers as well, because they're run differently. ANCA's indirect immunofluorescence, and ELISA's a direct immunofluorescence assay. So that's the difference between those two tests.
And the last thing too is I would love an EKG too. And the only reason I say that is I assume this is sinus and it's pretty mild, but if this patient had new evidence of, say, heart block or any arrhythmia, you can also consider, amyloid is classic for that, so that could be a hint. I know we're going to get our paraprotein workup, but it could be an early clue to amyloidosis as well, and presence of low voltages too on EKG. So yeah, Mariana, curious what's next.
And the TSH.
Awesome. So I'm afraid I'm going to disappoint you two, but I have a few more data here, and then I think you can try to narrow down the differential diagnosis. And in the next aliquot, and I will reveal the final diagnosis. So the LDL was 174, HDL was 17, the TSH was within normal limit. The SPEP came back without monoclonal gammopathy. The capital lambda ratio was normal. Antistreptolysin O was normal. Na negative. C3 and C4 were within normal limits. ANCA was negative. GBM was negative, and cryoglobulin screen was also negative. And I'll stop here.
Okay, so certainly with the LDL being 174, there's certainly a hyperlipidemic state. This certainly does meet the criteria of nephrotic syndrome. The SPEP has no monoclonal gammopathy. That still, at least for me, may not rule out that there may be a primary amyloidosis, because again, you don't necessarily have to have the paraprotein component to have a primary AL amyloidosis, so it doesn't rule that out for me. Kappa lambda ratio, you always want the number, what it means, because if someone has chronic kidney disease, these are large molecular weight proteins. So what happens is, I always have to look this up, but I think either lambda is bigger than kappa or kappa is bigger than lambda. But what that means is you're always going to have a ratio that's going to be like anywhere from like 1.5 to 3.1 with chronic kidney disease. And that's just because, they are not able to get excreted because of large molecular size of those light chains. The ANA is negative. So if we're talking about, amyloid, it still, for me, does not rule it out, although it may make it less likely with an SPEP. Again, I've seen AL associated, without the presence of paraproteinemia. I still think, I'm thinking about paraneoplastic membranous. Obviously, I'm going to want a kidney biopsy to see what's going on here. I think less likely minimal change because, usually there's worsening of the kidney function is usually worsening anasarca when they present, and it doesn't really have that flavor. Patients with minimal change, here's another important teaching point. When someone has significant anasarca and significant hypoalbuminemia, they're at risk for AKI because of nephrotic range proteinuria. Those patients, if they have AKI, you need to treat them with IV albumin. They can develop something called nephrosarca. The hypoalbuminemia in and of itself, when it's because of the severe nephrotic syndrome, they really can develop decreased effective arterial blood volume. You really only see that with minimal change. Again, minimal change, one teaching home point, it's aggressive. When it presents, it's like, I'm here, it's not subtle. So I think this is less likely minimal change. And again, I may be dead wrong, but just with the nature of the appearance and the fact that the kidney function is normal. FSGS, now FSGS has many different, there's like 9 different histologic presentations. The classic one is the collapsing variant, which is viral induced, like HIV, like COVID. Those are patients who present with florid nephrotic syndrome and have acute kidney injury. But there are different kind of variants that you'll see on biopsy, things like a glomerular tip variant. And the histologic subtype of FSGS actually portends a very good prognosis depending on the histologic subtype. So this could be one of those things as well, although what would argue against that is the degree of nephrotic range proteinuria. I still think a paraneoplastic membranous is still in my differential. I still think membranous would still be here. I still think amyloid would still be part of my differential as well. And then you can also think about weird things that can also be part of this, and like things like fibrillary glomerulonephritis, aminotactoid glomerulonephritis. Those are like amyloid related type processes. And the difference in a biopsy is the length of the fibril, the organization of the fibril, and whether it's a parallel or linear array on biopsy. But those would still be things that I would think about in someone like this. Fibrillary GN, you think about amyloid-like processes as well. Again, the only way to make that diagnosis is a kidney biopsy. There's really no predictive method for something like a fibrillary or aminotactoid glomerulonephritis, glomerulopathy. That's all I got with this one. I'm probably forgetting something, but the mind just going a mile a minute, and I can't think of anything else right now. Sorry. All right.
Yeah, if I were to guess what Mariana's going to give us next, I feel like the one thing she withheld is a PLA2R. So I wonder if it's possible that she's going to give us a PLA2R next, or a kidney biopsy. I feel like that's our, like you're saying, our only road to the answer. And Rich, say that PLA2R is positive. I've heard that. Do you renal biopsy these patients like risk stratum, or you can just
if
just treat, right?
If a PLA2R is positive, it is primary membranous nephropathy until proved. Now, there are different antibodies for membranous. The second most common one is an let me see, THSD7 is a thrombospondin. I always forget, it's like 35% of the time. And the third one is called anti-NEL1 antigen. These are antibodies to podocytes, right, on the glomerular basement membrane. And there's more and more that when they do a biopsy that you can talk to the renal pathologist and get these other different antibodies. But the only one that you can measure in the serum is antiphospholipase A2 receptor. If that's positive, it's primary membranous, and you do not need, the only time you would do a biopsy is if they have massive proteinuria and significant AKI, because you want to get a sense of what's the degree of damage to the kidney, degree of tubular interstitial. That's it, THSD7A. Thank you. That is the second most common one. That's like 35% of the time, and I think that can be positive with paraneoplastic glomerulopathy. They will run that on the kidney biopsy itself. But it's not yet available in commercial, although it may be coming in the next couple of years, is my understanding. Oh, that's awesome. Oh, thank you, Mengu. Thank you. Awesome. Very cool. All right, go ahead. I'm sorry.
All right, Mariana, what do you have for us?
Yes, so Mark, you nailed it. So the next adequate, I'll bring the PLA2R antibody, which came back strongly positive, and they also performed a biopsy in this patient, which showed membranous glomerulonephritis, and the final diagnosis was primary membranous nephropathy. Before I forget, I just would like to thank you, Seth, for kindly sharing this case with me so I could present for you all tonight. And it was a very, very amazing discussion. And I know you have like some more peers to share with us, but something that I'm very curious to ask, do you think that like the kidney disease that this patient had, stage 3A kidney disease, was already because of the glomerulonephritis, or this is something new, that like a new onset glomerulonephritis that is associated with like a previous diagnosis of chronic kidney disease?
I would want to know, the way to answer that question is, what's the degree of tubular interstitial fibrosis on biopsy? You know, when they do a biopsy, they're just not going to give you the glomerular process, but they will tell you under light microscopy what the degree of tubular interstitial fibrosis is. You know, this is a new diagnosis, and we'll talk about primary membranous in a second. But if he has had long-standing hypertension, or he has stage 3 chronic kidney disease, he has a baseline of 1.5, and he's coming in with a creatinine of 1.6. So I think that just given that history alone, this is more de novo primary membranous. And I would also, again, if he has significant tubular interstitial fibrosis or echogenic kidneys on ultrasound, is going to point that he has more of a prior chronic component. Now, the primary membranous, again, usually this is de novo diagnosis. You're not expecting that degree of, I'm not really expecting seeing fibrosis here. One of the things about treatment, so when you think about membranous, you think about rules of, 1 minute, rules of 1/3. 1/3 do fine by themselves and stay okay. 1/3 will either stay the same or improve. So you have 2/3 of the time, things will either stay the same or things will improve. The 1/3 of the time they'll do worse, and usually it's the degree of proteinuria. We can see patients with membranous nephropathy with like 4 to 5 grams of protein, and may not just only do things like an ACE inhibitor. If they have chronic kidney disease, consider something like Jardiance statin. When the protein level is this high, at 9 grams, now the time you start talking about treatment, and there's different treatment regimens, but you're going to see a lot of Rituxan being used, anti-CD19, CD20 antibody for something like this. It's definitely responsive. You may see some doctors use a calcineurin inhibitor, things like Prograf. And then there's new regimens that people are coming out with in terms of immunosuppressive. And then there's different types of other antibodies, that are coming out in addition to Rituxan. Obviously the treatment would now be treating the cellulitis, doing the biopsy, and then treating, talking about diuresing, putting them on an IV diuretic, and then looking at complications and seeing where, are they truly immunosuppressed? How bad are they? And then talking about treatment. But certainly given the degree of proteinuria at 9-10 grams, I would be talking about treatment, although given the fact that the patient has preserved kidney function, I don't know that we have to do it right away, because we need to treat an infection. We need to look at infectious etiology, infectious risk, things like that. So what happened with the patient?
So the patient, he was initially managed and then he was discharged, and they actually got the biopsy result during the follow-up, the
Okay.
outpatient follow-up. After the biopsy result, he was referred to nephrology, and that's all I know.
Okay. No, great case. You know, again, normally if the proteinuria is less, you're not doing a biopsy, but in someone with 9 to 10 grams of proteinuria, yeah, you're doing a biopsy. But the degree of tubular interstitial fibrosis you'll definitely see um, on the biopsy to get a sense of what, you know, if there was a chronic component prior to this. Very interesting.
Rich, can I ask, not to, I know we're running out of time, but can I ask one diuretic question, kind of like nerdy?
Sure.
I've read and been told that, mainly based, I think, on more rat models and maybe some like retrospective human studies, that bumetanide is preferred with proteinuria because it's less protein bound in the tubules. Do you prefer, and then I know like nephrologists, and me too, I like torsemide a lot for chronic kidney disease, but do you prefer bumetanide as diuretics for nephrotic syndrome?
In terms of IV, you know, I look at I look at both of them because it's IV, so you're going directly into the blood. So it's you know, I get more bang from my buck, I think, with a Bumex infusion than I do a Lasix infusion. Although I look at the ones as being equivocal. For a diuretic like this, you know, again, you're looking at effective dose of a diuretic and frequency of the dosing. So this person has chronic kidney disease, and again, your diuretics, your loop diuretics are going to be protein bound, less of an issue intravenously. But you know, certainly given hypoalbuminemia, I'm going to want a higher loop diuretic because it gets into the kidney through the organic, I think it's either organic cation secretory pump, you know, through tubular secretion. So it's not dependent on GFR. So, you know, I would be starting at least 80 milligrams IV, if not higher, and doing like 120 Q8. You could start them on a drip as well. There's no difference in outcome between intermittent diuretics and drip. It's just easier on the nurses and it's more sustained. So you don't have to take the time to build up a therapeutic level in the kidney for a sustained diuresis. So I'd be interested to know what was done diuretic wise for the patient and what they chose. In terms of oral, again, as you know, torsemide is the most oral bioavailability, then Bumex, and then Lasix. So this hopefully I did this justice. I mean, there was a lot to really go over here. Interesting stuff.
Dr. Rich, I think that I can speak for all of our people here, and hopefully the ones on YouTube, that we are all like stunned by the amount of pearls that we got. Is like having a round of nephrology words with you. Just a last question: what would the long-term monitoring strategies be with this patient? Like,
so you can actually, so just like with lupus, you can follow anti-double-stranded DNA levels in terms of severity of diagnosis. You can actually follow, you're following the antibody levels, what's the antibody? I'm sorry. The phospholipase A2 receptor antibody, you can actually follow them. And actually, if they begin to rise again, it's a great indicator for primary membranous that you may actually be either have a partial response, or if it increases that you're getting a relapse of the nephrotic syndrome. And you can, or of the membranous, you can actually get a rise in the serology before you see an increase in urine protein excretion. Is, you know, so that, you know, what they'll do is, you know, you're following patients as an outpatient, they get treated with whatever regimen the nephrologist is usually is going to be one of those two things. And then you're following phospholipase A2 receptor levels and urine protein creatinine ratio levels. And if you see a rise, you know, the question is, do you start treatment? You would watch them. Again, membranous, we tend to be a little bit less aggressive, only because, again, you have 2/3 of the time you're either going to stay the same or it's going to get better on its own. So you have a higher risk of either normalization or a partial response. And someone with this degree of proteinuria, if they started developing increase in proteinuria or rise in titer, you would have a lower threshold to reinitiate therapy.
Thank you so much for that. I'm definitely rewatching this VMR on YouTube, like noting down absolutely every single thing. And talking about teaching points, which Simi here, big shout out to her because she catched everything. I have another difficult task for you, friend. Would you like to share with us your favorite 3 teaching points to be mindful of Dr. Rich, Mark, and everyone's time? I'm just impressed.
Yes, there was a lot of learning, and I'll try to share 3 important points. I think one important point is that when we have unilateral versus bilateral edema, in unilateral, we can think about cellulitis and venous insufficiency, while in bilateral, we can consider heart, kidney, and liver. And we learned that hypertensive nephrosclerosis is linked to the gene called APOL1, and it is seen in African Americans. And we learned that marijuana can inhibit CYP3/4, and tacrolimus is known to have significant interaction. And then we studied a lot about the types of nephrotic syndrome. And we learned that amyloidosis and multiple myeloma can cause enlarged kidneys. And we learned that membranous nephropathy can be detected with antibody TSHD7A, which was new to me. And as for treatment, we give calcineurin inhibitors, certain antibodies, diuretics, and loop diuretics are not affected by the low GFR, so are really effective. And I tried, and it was a great learning experience, and I tried to summarize some of the points. Thank you, everyone.
Amazing. Thank you, Simi, and thank you, Dr. Rich, Mark. Next week, we have another nephrology VMR, again with Dr. Rich, like leading us and giving us all this like big box of teaching points. Thank you so much. Really, I hope you enjoyed this as much as I did. And again, shout out to Simi. This was an amazing session. See you next week.
Thank you, guys. Have a great night. Mark, great job as usual. Yaz, great job. Thank you, everybody. I appreciate the interaction. All right. Have a great one. All right. Gotcha.